So before we really dive into this, I want you guys to kind of start thinking about heart failure and what heart failure is. So we know that we respond to a fair amount of calls for patients that are suffering from heart failure, but do we really ever take the time to stop and think if it's really a left-sided issue or a right-sided issue? And I know that we're kind of accustomed to doing this now with 12-lead EKG. If we're doing a 12-lead EKG and that finding comes back that the patient is having an inferior wall infarct, and we would know that based on elevation in 2, 3, and AVF, or at least 2 of those leads, then it would put us, in our forethought that we need to also be doing a right-sided 12-lead to rule out whether this is right-sided or left-sided, because we know that the treatment modality is going to be different depending on which one it is. So just to kind of refresh there for a second, the reason that we're doing that, and the reason that we only have to do that if it's an inferior wall infarct, is we know that the inferior wall gets blood supply from both the right coronary artery and also off of a branch of the left coronary artery. So the fact that it's infarcting tells us that there is a blockage, but we have to take that one step further and determine if the blockage is truly in the right side or if it's really in the left side. And that's the only one that we have to do that for. So I know oftentimes students or even folks that I've worked with in the past, they'll bring an EKG that shows a septal or an anterior wall infarct, and they're proud of the fact that they went ahead and did a right-sided 12-lead EKG. It's not harmful in any way, but it's really not necessary, because we know that if they're having a lateral, a septal, or an anterior wall infarct, the problem is definitely off of that left main coronary artery somewhere. The one that we don't know is the inferior wall. So the inferior wall is really the only one that we truly have to separate out and say, okay, is this a right-sided problem or is it a left-sided problem? And the reason that we're doing that is, as you should know, hopefully at this point, it's going to depend on whether or not our treatment is going to be nitroglycerin, if it's left-sided, or if we're going to end up dumping some fluids to them to get Starling's mechanism involved, where we stretch out the right ventricle in hopes that it contracts harder. So left-sided is nitro, right-sided is going to be fluid. Similar thought here with heart failure. Why are these individuals going into heart failure? Is it a left-sided issue, i.e. hypertension, afterload, the pressure to which that left ventricle has to pump against to get blood to eject from the left ventricle? Or is it a right-sided issue? And if it's a right-sided heart failure issue, why is that? Is it related to a pulmonary hypertension? So they've got high pressures in the pulmonary or the lung network that is now making the right side of the heart fail. So these are the questions that we should really be thinking about and asking when we're transporting and trying to care for these patients, because much like the patient that is suffering from an inferior wall infarct, our treatment may be a little bit different depending on if it's a left-sided or right-sided heart failure. So the objectives here, we're going to talk about heart failure, the physiology, and some of the clinical markers that are associated with that. We'll talk about the differences between left-side and right-sided heart failure. And if you can just kind of approach it with that mindset that we were just talking about, kind of similar to the inferior wall infarct, then you're going to be ahead of the game here. We'll also talk about the assessment of the patient with heart failure, common signs and symptoms that are associated with that. And what I really want to talk about there primarily is, how do you differentiate from a patient that is having heart failure versus somebody that you pick up at a nursing home, for instance, that has rails, but is not actually in failure. They're more in a pneumonia situation. So we need to be aware of those things, because the last thing that we want to do is treat a pneumonia patient based on them having fluid overload, when in fact we know they probably need fluid administration. And then we'll talk about updated pre-hospital management for the patient that is in left-sided heart failure. So before we go too much further here, I want you guys to just kind of keep in mind that you have both systolic heart failure and diastolic heart failure. And if we go back to just normal physiology and normal EMT, basic EMT skill, and talk about blood pressure, we should remember that systole, or your systolic pressure, is going to be pumping pressure. So anytime we're looking at systole, we're looking at how much pressure it is taking for that left ventricle to pump blood from it. So if we have a systolic heart failure, what we know is that that left ventricle, the muscle is weak and the contractility is going to be poor, leading to a pumping issue. If we have diastolic heart failure, remember diastole is the filling pressure. So that is why those numbers cannot be reversed. We can never have a higher filling or diastole than we do pumping. Pumping always has to be able to overcome that. So if we have diastolic heart failure, then we know that that left ventricle, the muscle itself is unable to relax properly. It is rigid, it is stiff, it is stenotic for whatever the reason is, probably a hypertension concern. But because that thing doesn't have the ability to relax appropriately, what's going to end up happening is that it doesn't have the same capacity for filling to take place. So this ends up becoming a filling failure. So systolic heart failure is going to be an inability for the heart to pump appropriately. And then diastolic heart failure is going to be the inability for that left ventricle to fill properly. So let's talk just a few key terms here. We have afterload, cardiac output, preload, and then pulmonary edema. And these are words that as you're going through EMT and or paramedic school, you may kind of throw around, but do we really know what they actually mean and what they stand for? And I say this all the time doing tutoring or talking with the students that are in our paramedic class, that I think that as educators, one of the biggest disservices that we do is the medical terminology portion. And actually, Brandon and I just spoke about this, that if you understand the medical terminology piece, most of the time you're going to be able to kind of break down the words to where you can figure out what it's trying to talk about at least. So an example of that is we talk about afterload. And I would venture to say that if I walked up to most EMTs and or paramedics in the field and said, in your own words, tell me what afterload is, they would probably stumble upon those words for a few minutes. And that's okay as long as they understand the concept. But what afterload is also known as peripheral vascular resistance, and it is also known as left ventricular end diastolic pressure. And those are a lot of words, but they all mean the same thing. And what we're truly trying to get to here is how much pressure does the left side of the heart have to pump against to get blood to eject from it? We know that that left ventricle is where all of the workload is coming from. It's the biggest part of the muscle. It has to pump through that aortic valve into the aorta and then ultimately out into systemic circulation. So if we have any type of blockage there, or we have a stenotic aortic valve, or we have atherosclerosis or buildup of different particles inside of the aorta itself, then we know it's going to increase the pressure that which that left ventricle has to pump against to get blood to get out from it. So afterload, peripheral vascular resistance, and then the other one is left ventricular end diastolic pressure. Well, I told you that diastole is filling pressure. So at the end of filling, the end diastolic pressure would be pumping pressure, which is exactly what we're talking about here. So afterload is just what that left ventricle has to pump against. Cardiac output, on the other hand, is the amount of blood volume that the heart pumps in 1 minute. And the way that we get that is we take their heart rate and then we multiply that by their stroke volume. And stroke volume is the amount of blood that is being ejected from that left ventricle with each beat. So if we take whatever the number is for stroke volume and we multiply that by whatever the heart rate is for the minute, that ends up giving us the cardiac output. And for those of you that are already certified and licensed, it doesn't necessarily mean a lot to you as far as cardiac output and stroke volume and all those different formulas. But if you're in class, these are certainly things that you're going to be expected to know as you progress through your class and ultimately take and pass the national registry, hopefully. So if we know what afterload is, and that's the pressure that the heart has to pump against to get blood to eject, then preload is going to be the amount of blood that is coming back to the right side of the heart. so that it can be picked up with oxygen again and then ultimately circulated around through systemic circulation. So preload by definition is the amount of blood the heart receives from the venous system. And we're going to talk more about this with regards to the superior vena cava and the inferior vena cava as we progress through here today. So remember, the superior vena cava is going to take blood flow from the head and the neck and dump it into the right atrium. And then the inferior vena cava is going to take all of your blood flow from the rest of the body and then put it in the same spot. They're both going to end up hopefully in the right atria so that it can ultimately make its way through the normal circulation through the heart and the lungs. And then pulmonary edema. We respond to calls for this all the time. You put your stethoscope on a patient's lungs, and all of a sudden you start to hear a bunch of rails or crackles, you may say. So we know that the patient is suffering from pulmonary edema. And what this is no more than just accumulation of fluid in the lung tissues and the alveoli. So when we hear fluid, we have to do something to try to manage that fluid and allow those alveoli an opportunity to get the gas exchange that they're actually looking for. So we'll talk more about alveoli and kind of hopefully relate this to you guys a little bit easier to where you understand what we're truly trying to do here. So a lot of this is going to end up depending on, and you can certainly appreciate that as far as afterload, preload, on how much vascular tone there actually is. So if there's the ability for the vascular tone to vasodilate and vasoconstrict, and we know that that happens in that tunica media, the middle portion of the vessel, that's where all that muscular ability is, then we're going to end up having probably a decent ability to manage preload and or afterload. If the vessel walls start to become very rigid and stiff and we can't do that anymore, this is a situation where you're now going to start seeing hypertension. So the vessel wall is becoming narrowed and or stiff. It doesn't have the ability to contract and dilate as it should. So now when you take the blood pressure, their blood pressure is going to be high. And that is one of the main key findings in a patient that is suffering from congestive heart failure is they're going to be hypertensive. So I want you to always think about that. The problem that we run into, you respond to a nursing home, 99% of the people that are in the nursing home probably have chronic hypertension. So is this really a hypertensive congestive heart failure issue, or is this pneumonia and they just happen to have hypertension with it? So the other thing that we should be looking at is unilateral versus bilateral problem. If a patient is having congestive heart failure and all things are considered equal, they haven't had a lung removed or something like that, then they're going to end up having a bilateral issue. So when you listen and you hear rails, you should hear rails bilaterally, and it should be fairly equal, which is why we always compare one side to the other. The other thing is, if they're truly just suffering from congestive heart failure, they probably do not have a fever to go along with that. So if there's any type of infectious process, if it's a unilateral finding, meaning that you only hear it on one side, I would be leaning more towards the patient as having an issue with pneumonia and withholding all of the treatment as far as Lasix, which I know in the Northern Kentucky, the Southwest Ohio protocol, Lasix has kind of been removed, but that doesn't necessarily mean that that's the case across the board. So I would use reservation in giving them any type of diuretic because you're only going to make things worse. If you think that they are a pneumonia patient, symptom management and then fluid administration would be the appropriate treatment there, as long as you're monitoring lung sounds. If you truly think that it's a congestive heart failure issue, then certainly the treatment modality, which we'll discuss a little bit later, is going to be based on giving this individual nitro primarily. And we'll talk about why that is and why it's more beneficial than giving a patient just a loop diuretic such as Lasix. All right, so why heart failure versus cardiogenic shock? So most of you have probably, we had a patient that we transported that was in failure. And this is a pretty common thing and a fairly common EMS call for service that we would get. But I don't know that I've heard a lot of people come back and say, yeah, I had a patient that was in cardiogenic shock. So what we need to do is be able to differentiate between the two. So remember that heart failure is going to end up being a broad term, and there's different syndromes, and a syndrome is just a collection of symptoms that go with patients that are in heart failure. So are they a failure patient or are they a cardiogenic shock? And basically what it boils down to is, are the metabolic demands of the patient being met? So in heart failure, the pumping mechanism has decreased. So we're talking about systolic heart failure because the pump is not working correctly, but the metabolic demands of the body are still being met. They're still getting enough oxygenated blood circulating around that they're able to metabolize and get oxygenated blood to all of the tissues. Are they having difficulty breathing? Sure, but at the underlying level, they're still having the metabolic portion met. And a patient that has switched from heart failure over to cardiogenic shock, we got to keep in mind that the metabolic demands of the body are no longer being met due to the heart's inability to pump. So they are definitely intertwined. They are definitely related, but you have to be able to look and see if the patient's metabolic demands are being met or not. And basically the easiest way for us to do that, honestly, is probably look at mean arterial pressure. So if we can look at the map and figure out what the map is, we know that that is tissue perfusion pressure, which is another name for mean arterial pressure. And if you guys are like, okay, where are you going to get that information from? Always go back to taking the patient's blood pressure, and then you can either do it manually, or you can simply look at your machine and find the number that is in parentheses. So if you find that number that's in parentheses, depending on where that number lies, then the patient is probably getting the metabolic demands that they actually need. So in cardiogenic shock, the intensive care units, they start worrying about a mean arterial pressure of under 60. So if it's less than 60, I would be concerned about that, and they're probably heading towards the cardiogenic shock algorithm. If they have a mean arterial pressure and it's still 85, 90, or even higher than that because the patient's hypertensive, then they're probably having their metabolic demands met. So we know that we're getting oxygenated blood down to the tissues themselves. So if we look at normal anatomy and physiology, we should kind of think that this is the depiction of what it would typically look like. So you can see on the right side of your screen there, the diagram that is actually an animation, and you can see that the left side and the right side are kind of doing their thing. So signs and symptoms of heart failure will depend on which side of the heart is failing. And I cannot stress this enough. And hopefully, you know, we're not beating this horse too much, but I want you all to think about any time that you're dealing with a patient that has any type of cardiac issue, it is imperative that we figure out if it is left-sided or right-sided. And there are some simple findings that are easy and cheap for us to do that will help to determine that. And I'll kind of leave this here for just a second. If we just isolated and said this is a left-sided issue, so a left-sided issue, what I want you to think about is how that would actually back up. So we know that if the blood flow through the normal heart, and I'll start from the beginning, you have your inferior and superior vena cava, which I mentioned, it goes into the right atria. From the right atria, it goes through the tricuspid valve, which is right here, which enters down into the right ventricle. From the right ventricle, it goes through this valve right here, called the pulmonic valve, into the pulmonary artery. Once it is in the pulmonary artery, it gets into the lungs where gas exchange takes place. It comes back via the pulmonary vein into this left atria. From the left atria, it's going to go through this mitral valve into the left ventricle. And from the left ventricle, it actually gets ejected upwards through the aortic valve into the ascending, the transverse, and in the descending aorta and out to the body. So if I were to say that this left ventricle, which is actually on the right side of your screen, remember that we're looking at a patient here. If that left ventricle fails, then we have to be able to figure out how that would back up. So if we know that the left ventricle has failed, then what you're going to find is that it's going to go up through this mitral valve. It's going to back up into the left atria. from the left atria. It's going to go backwards through that pulmonary vein and then into the lungs. And this is why a patient that is suffering from a left-sided issue is going to have wet lung sounds. When you listen to their lung sounds, you're going to hear rales, and you're probably going to hear that bilaterally. It makes perfect sense. The issue becomes when that continues to back up. So if I just take that further than what we've already done from the lungs, it's going to end up backing through this pulmonary artery. It comes into the right ventricle. From the right ventricle, it goes up through the right atria and then into the superior vena cava, which is what's going to end up giving us jugular venous distension. And then it's going to end up going down into the inferior vena cava, which is why we get the sacral or scrotal edema. And we're also going to get pedal edema that goes along with that. So if you were to be asked, is a patient that is having sacral edema, pedal edema, and jugular venous distension, is this an early sign or a late sign of a patient in heart failure? Hopefully you guys understand that this is a very late sign, because it has taken a tremendous amount of backup for those things to actually start to show. If we take a whole different approach and say this is a different patient, and it is now this right ventricle that is the problem. Well, if my right ventricle has failed, you can see when the right ventricle fails, blood just backs up into the right atria, into the superior and inferior vena cava. So yes, you're going to have signs of right-sided heart failure, i.e. they're going to have distended jugular veins. You may end up having hepatojugular reflex. When you press on their liver, the neck veins get big, and that's just because of a high pressure on the right side of the heart. But when you listen to their lungs, the lungs are going to be completely clear. The reason for that, the fluid can't reach the lungs. So if it can't reach the lungs, you're not going to hear rales bilaterally. You're actually going to have a patient that complains of difficulty breathing, but has clear lung sounds and signs of right-sided heart failure, i.e. jugular venous distension, hepatojugular reflex, sacral edema, scrotal edema, pedal edema, all of those signs that the systemic circulation is actually where this is backing up to. So similar to the MI patient, try to differentiate which side is which. So failure of the left ventricle is going to result in a backup of blood into the lungs, and then potentially is a late sign into the right ventricle. Failure of the right ventricle will back up immediately into systemic circulation through the vena cava, either the superior or inferior vena cava as such. So hemodynamic congestion. So if we have a patient that is having the difficulty breathing that goes along with this, it is probably because they have pulmonary congestion as well. So they're going to say, I can't breathe. And that's because I have excess fluid in that the pulmonary network itself. How are we going to know that? Honestly, the only way that we're going to be able to tell is with a stethoscope, and we're not going to be able to get a really good finding there other than do we hear fluid or do we not. So these individuals are going to benefit the most from having a chest x-ray performed once they get to a receiving facility. All right, so left-sided versus right-sided. So the lungs, the liver, and the kidney are affected in patients that are having heart failure, and this is because of low cardiac output. We know there are certain vital organs that have to get blood flow continuously. The heart, the brain, the kidneys. If we do not have the ability to pump blood from that left ventricle to get it to all of those different tissues, then we're going to end up starting to have other organ damage because we're not getting oxygenated blood where it needs to be. So the breakdown of patients that are having heart failure, about 2/3 of the patients that are having heart failure is going to be from a systolic dysfunction. And these are patients that have had a myocardial infarction. So they've had an MI, and now that left ventricle is not working appropriately. And because of that, they are now in heart failure. And this equates for about 66% of them. About 33%, or the other 1/3 of the patients, is because of diastolic dysfunction. And this is because of chronic hypertension. If I have high blood pressure continuously and it never gets fixed, it never gets addressed or under control, then that pressure just continues to rise. and I end up having a diastolic heart failure. So kind of the difference between left-sided and right-sided heart failure. So let's look at both of them. We'll start with right. So right heart failure, the number one cause of right-sided heart failure is left-sided heart failure. So if the left side fails, the right side is going to be put under more pressures that are higher than what they're normally under. So the right side is ultimately going to fail as well. So the number one cause of left-sided heart or right-sided heart failure is left-sided heart failure. Other things are cor pulmonale. So cor pulmonale is basically a right-sided heart failure, and its pulmo is Latin, meaning lung. And it actually had a couple different derivatives. It was pulmonalis, and then ultimately this ended up getting changed over to cor pulmonale. So it's basically a failure of the a right-sided heart failure brought on by a lung issue. So that could be pulmonary hypertension, which is the very last bullet point down there. So the pressures inside the pulmonary network are high, and that causes that right side to fail because now the right ventricle is unable to pump blood into that pulmonary network. Other things that will cause right heart failure, right ventricular infarction, exactly what we've been talking about when you see patients that have that inferior wall infarct. Is it a left-sided issue or is it a right-sided issue? Tricuspid and pulmonic valve damage. So this could be a stenotic valve, meaning that anytime that you hear the word stenosis, just think about that being a stiff valve. It's not able to open and close the way that it should. So obviously, if I'm having to pump against something that is unable to open the way that it should, it's going to make it a little bit more difficult for me to get flow past that. And if you just kind of relate that, if your mind is more from the fire side, you've got an intake valve that is sticking, you're not able to open that intake valve all the way. You're obviously not going to get the same amount of water from your hydrant going into your truck. Same concept here, the tricuspid and pulmonic valve, if they're sticking, you're not going to get the same amount of flow through them. A pulmonary embolus. So I want to take a minute to talk about pulmonary embolus. When we think about a pulmonary embolus, we think that those patients are pretty easy to identify in the field. They probably have some sort of a history of immobility, and that can be either self-induced or because they can't help it. So, i.e., a patient that has had recent surgery. Maybe it is a pregnant female that is on bed rest. Maybe it's somebody that has traveled long distances, i.e. a truck driver and or a passenger or a pilot on an airplane, and they haven't been up and moving around. So you end up getting microclots in the lower extremities most commonly. And then ultimately that microclot basically breaks off and it starts circulating around. Well, it's in the venous system. So through a series of networks, it ends up coming up and it gets dropped into that right atria, and then it starts making its way through the heart. The reason that the pulmonary embolus occurs where it does is that is the narrowest portion that it comes in contact with. The right atria is a decent sized vessel or a decent sized chamber. It's easily able to make its way through the tricuspid valve and down into that right ventricle. The problem lies is after it goes through the pulmonic valve, that pulmonary artery gets narrow. And when it's narrowed and I have a clot, that clot is ultimately going to wedge into that narrowest portion, and now I'm unable to get blood flow past it. That is where your pulmonary embolus comes in. It is always going to end up being in the pulmonary artery because it's the narrowest portion, and that's where it's going to get caught up first. So obviously, if I have a clot in the pulmonary artery and blood flow can't get through it, it's going to back up, i.e. right-sided heart failure. And then ultimately, as we mentioned earlier, pulmonary hypertension. Left-sided heart failure, which is probably what most of you are more comfortable and more familiar with, is going to be pulmonary edema, hypertension. Hypertension is going to be the number one cause of a patient having left heart failure. And that's because the left ventricle is unable to pump out the way that it should. Left ventricular infarct. So we've had a massive MI that has now affected that left ventricle. And then like the tricuspid and pulmonic, you can have valve issues. So mitral and aortic valve, which are both found on the left side of the heart. and then cardiomyopathy. And cardiomyopathy is just an enlargement of that left ventricle. So if the left ventricle gets to the point where it is so big, it's not going to have the same function as it should under normal conditions. So one other point that I want to make here, and it is pretty eye-opening, as again, when we do tutoring and when we talk about these things in continuing education, but when we're doing a 12-lead EKG, remember that we are only looking at the left ventricle. If you guys are doing just standard 12-lead EKGs, you put your V1 through your V6, think about where those V1 through your V6 are going. You have 1 and 2 on either side of the sternum. 4 is directly under the nipple line on the left side. 3 goes in between 2 and 4. And then 5 is anterior axillary and 6 is mid-axillary, still in about that 5th intercostal space. They're taking pictures of the left ventricle. If we want to look at the right side of the heart or the back side of the heart, the posterior portion, we have to move our leads. So left ventricular infarct is big. If we can figure this out early on, it may be that the patient can get appropriate treatment in the hospital to prevent them from going into heart failure from this. So, you know, the old saying, time is muscle, and that is very true. And especially when we're talking about a patient that could ultimately lead into left heart failure. So signs and symptoms that go along with each one of those, and we'll stick with right at the beginning. So right, we have jugular venous distension, peripheral edema, and ascites. So ascites is where we have a fluid accumulation in the abdominal cavity. Think about how this all works. So the liver is really what is responsible for draining and filtering everything out. So we have the major vein that drains the liver, the hepatic vein. If things are under a high pressure, it doesn't work the way that it's supposed to. So now all of a sudden I start to have fluid build up, and that fluid is going to build up into the abdominal cavity, i.e. a patient that has ascites. So there are different things that can cause patients to have ascites. And just to kind of throw out a few of the different ones, heart failure obviously is one. A patient that has cirrhosis of the liver is going to be another one, because the liver's not draining the way that it should. Cancers, different types of cancers, i.e. liver cancer is going to end up being one. TB, tuberculosis, is one that can do that. And that's because the lungs become stiff, and all of a sudden now we have pressure build up with inside the thoracic cavity. Renal disease, so your kidneys are not functioning the way that they're supposed to. Pancreatitis can do it. And then there are a multitude of other conditions that will lead to a patient ultimately having ascites. If they have an ascites, what they're going to end up having to do is go in and they have to tap the belly. They're going to remove fluid from the belly. And sometimes, I mean, it is an impressive amount of fluid where they'll end up drawing off 1,500 or 2,000 or even more cc's of fluid directly from the belly. And they can get this done a couple of different times, depending on how quickly that is filling back up. Right-sided heart failure, signs and symptoms, sacral and scrotal edema. These are just because of gravity. So the fluid is going to make its way to the lowest portion, and the sacrum and the scrotum, there are often times where those are going to be, because the patient is going to want to sit up. They can't breathe, so they want to sit up, and that's why that fluid starts to drop in the way that it does. Orthopnea, and then hepatojugular reflex. And hepatojugular reflex, if you take and press on the liver, and you should kind of be able to feel the liver borders. If you press on the liver, you're going to end up saying that the neck veins get big, and that's because of that high pressure on the right side. Left-sided heart failure, they're going to be anxious, they're going to have tachycardia, they're going to be hypertensive, and that is the key takeaway here. Hypertensive emergency. These patients, that is why they are now in left-sided heart failure, is the hypertension. They're going to be pale, cool, and sweaty, and that is because of a release of the catecholamines. So the body's wanting to fight this off. It releases catecholamines, and it's going to end up causing your vessels to shrink down. So now I'm pale and I'm also sweaty. Paroxysmal nocturnal dyspnea, so they have difficulty breathing at night. Orthopnea, again, these individuals are going to have rails and crackles, or rails or crackles, depending on which one you use in your normal terminology. They may have pink frothy sputum. Remember, this is a sign of polycythemia because they have increased red blood cell production just on the fact that they are hypoxic. So the body's not getting enough oxygenated blood. Your body's going to try to fix it. And then they have two other conditions that can be found: pulsus paradoxicus and pulsus alternans. So pulsus paradoxicus is when you have a reduction in your blood pressure. Your blood pressure will drop on inspiration. And if you think about that, I'm going to try to make this, as simple as I can. If I take a big breath in, the pressure on the inside of my chest just went up. And as the pressure on the inside of my chest goes up, the blood pressure is going to go down because it's not able to overcome that excess pressure. And that's what pulsus paradoxicus is a reduction in blood pressure anywhere from 10 to 20 millimeters of mercury, depending on what you read, based on the inspiration. And then pulsus alternans is a similar concept. So the pulse, when you feel for the pulse itself, you're going to have a very strong pulse and then a weak, strong and weak. And it is alternating, hence the alternans, because of that high pressure system. And there are other things out there when we're talking about alternans. You'll have an electrical alternans, and those are going to be found in your patients that have blood in the pericardial sac or cardiac tamponade. Because that electrical system obviously is going to be big and then small, big and then small. So it is electrically alternating. And that's because of, again, a high pressure system. So not very difficult to figure this stuff out and really understand and remember what the signs and symptoms of each one of those are going to be, if you can appreciate how they should look under normal conditions and what the normal pattern should be. So rails and crackles, hypertension, pale, cool, sweaty skin. I'm thinking left heart failure, especially if it is bilateral and they don't have a pneumonia or if they don't have a fever to go along with that. If it's a right-sided issue, then you're going to see systemic edema that is present because the right side is backing up directly into systemic circulation. So one of the things, and we told you guys this months back, that we've kind of been asked is, well, can you guys give us some idea of what the clinical markers are going to be if we have a patient that we transport in? What is a normal blood test for this? Because as you take your next patient in and now you hear, oh, they had a BNP of this. Well, what does that even mean? So the one thing that they're going to do if they think that this is a fluid overload situation is they're going to do what is called a BNP, a brain natriuretic peptide. This is a blood test, and that BNP will come back is either normal or abnormal, and that is going to base their decision on, okay, this is a fluid overload thing. So what BNP is it's a hormone that's produced by the heart, and the BNP level goes up as you have stretching of the myocytes in the myocardium. So as that ventricle starts to get bigger, it is going to release this hormone, and that is what causes this BNP to actually rise. So blood levels increase with excessive stretching of the myocardium and the ventricles. So they get bigger, it releases a hormone, you draw the blood level is up. We know that those ventricles are stretched out farther than they should be, and that's because they have too much fluid. Results greater than 100 in the PG is picograms per milliliter is considered to be an elevated or an abnormal level. So a normal BNP should be less than about 100. You can find patients that have that 100 to 500 and other findings be present, not necessarily that they have congestive heart failure. So 100 to 500, it could be that they have cirrhosis. It could be that they have pulmonary hypertension. So they may have to do some additional testing. But if that number gets to 500 picograms per milliliter or higher, anything over that 500, it is going to be pretty consistent with congestive heart failure. And other than that, it's really chest x-ray, stethoscope, and BNP. So there's not a lot of other tests out there as far as easy determinations of, is the patient in congestive heart failure or are they not? So what do we do for it? So it used to be, obviously, we would place these patients on oxygen. And then the first line medication for many, many, many years was going to be furosemide. We would give these individuals furosemide or Lasix. And if you remember back, and some of you may not even have ever used this if you're fairly new, furosemide is a loop diuretic. It works directly on the loop of Henle inside the kidneys. So it would actually pull the fluid into the kidneys and then allow the patient to diurese. And that's how you would actually start to get the fluid off of them. The problem with furosemide is this: it's a really good drug and it works very well. It's fairly safe as long as you're giving it to the right patient and you're giving it at the right rate. If you give furosemide too quickly, it can actually cause the patient to lose hearing and become deaf. So, it goes back to the old adage, when you don't know, you go slow. If you're not sure about how to give these medications, give them very, very slowly, because they can have untoward effects from them if you do not. So furosemide, great drug, but it takes a long time for it to work. I mean, once you give this furosemide, you're looking at 20 to 30 minutes before the patient actually starts to diurese. The problem is really a preload issue. If we can reduce the preload, if it's a left-sided heart failure issue, now that left side doesn't have so much fluid that it is trying to pump out. We need to reduce the right-sided pressure. So the way that we do that is we give these patients nitroglycerin. We've known this for years. It was just a while before the protocols finally caught up to say, okay, we can give a decent dose of nitroglycerin in hopes that we can reduce the preload. So nitroglycerin is now really the number one thing that we're going to be able to do. And it's just so that we can reduce the preload, hopefully on that right side, prevent all that fluid overload from making it to the left side so that the left side can pump out what it needs to pump out. In addition to that, obviously, position of comfort. We're going to have the patient on oxygen if need be. You can follow either your protocol and or the AHA recommendations there. We need to do that 12 lead EKG. Remember that one of the biggest reasons that patients suffer from left heart failure is a myocardial infarction. So we need to do a 12 lead to determine if the patient has in fact suffered from an MI, and we would know that based on a pathologic Q wave, or are they currently having a STEMI? And then the final thing is going to be CPAP, and not necessarily in that order, right? So continuous positive airway pressure. We need to get the fluid basically back to where it should be, keep the alveoli open so that they can have proper gas exchange take place for the amount of oxygenated blood that is going through the pulmonary network. So in the Southwest Ohio protocols, we're not really doing furosemide anymore. Nitroglycerin we can do, and actually you can do a couple of different times. You can give up to 3 nitroglycerin, and you can repeat that a couple of times. So make sure that you're familiar with the protocols, especially if you've been out for a long period, because you're probably still more astute to the furosemide and the 1 nitro, and that has definitely changed. So if it's a right-sided issue, the treatment's going to be a little bit different. Position of comfort, oxygen, and 12 lead are all going to be the same, but this goes back to Frank Starling's mechanism. We need to give them fluids. If we can increase the size of that right ventricle, then it is hopefully going to allow that to contract even farther based on Starling's mechanism and kind of kickstart the fluid being able to be ejected from the left side of the heart eventually. So ABC, IV, monitor, and then fluids based on Starling's law. Left side, ABCs, IV, monitor, CPAP, and nitroglycerin. A couple important statistics here, and this all goes back to the Center for Medicare and Medicaid, CMS. Reimbursement, and whether we like it or not, I don't like the billing piece of it either, and it's not why we do what we do for the most part. But at the end of the day, they're the ones that are paying the bill, and they're the ones giving the reimbursements for a lot of the stuff. Well, not only do they do that for us, but they also do it for the hospital, and they look at hospital readmission rates for patients that are in congestive heart failure. And what CMS, whether you agree with them or not, their thought is this: Heart failure is really something that we should be able to mostly prevent. Why do they go into heart failure? Well, hypertension. Okay, we can fix their hypertension. Well, maybe they have a diet that is too high in sodium and now they're holding fluid. Well, now we need to have some education about their diet. They need to have a low sodium diet. So CMS looks at it that if you have hospital readmissions, it's really the hospital or the provider issue for not educating the patient appropriately. But where they're getting some of this information from are the readmission mortality rates. So patients that have congestive heart failure and have had an admission to the hospital will have a 34% mortality within the first year. If they go to the hospital 4 times in 1 year, it ends up increasing their mortality to 60%. So it's something for you guys to just think about. You know who's in your district and who you've transported multiple times for the same thing. If you take them a couple times within a 1 year period, the chances of them passing away from this congestive heart failure issue are better than 50%. You're looking upwards of 60% or maybe even higher. So try to give them appropriate care, try to educate them if you can, and then transport them to the hospital for future and further care.